Good morning everyone. Today we learn about the repetitive nerve stimulation. It is a special nerve technique which is used to diagnose presynaptic and the postsynaptic disorders. First, coming to the basic anatomy and physiology, how is the action potential produced and the anatomy of the neuromuscular junction. Neuromuscular junction is the electrical link between the nerve and the muscle. Chemical neurotransmitter at the neuromuscular junction is the acetylcholine. Acetylcholine molecules are packed as the vesicles in the presynaptic terminal in a discrete units known as the quanta. These are the quanta. They are in the presynaptic terminal. These acetylcholine they are packed as the quanta. Each quanta contains approximately 10,000 molecules of the acetylcholine. These quanta are located in the three separate stores. First is the primary or the immediately available store, which contains 10 raised to 3, that is like 1000 quanta, which lies just beneath the presynaptic nerve terminal membrane. Then coming to the secondary or the mobilization store, that contains 10 raised to 4, that is the 10,000 quanta. They can resupply the primary store after the few seconds. First primary quanta are used, then secondary quanta, and last is the tertiary or the reserve store, that is 10 raised to 5, that is 1 lakh, which exists far from the neuromuscular junction in the axon and the cell body. Now coming to how action potential is formed, the nerve action potential depolarizes the presynaptic junction. In this presynaptic junction, the voltage gated calcium channels are activated, which results in the influx of the calcium, which will cause the release of the vesicles containing the acetylcholine from the presynaptic terminal. This acetylcholine binds to the acetylcholine receptor on the postsynaptic membrane, which opens the sodium channels which are located on the postsynaptic membrane. Then there occurs a local depolarization producing the end plate potential, which occurs at the postsynaptic membrane. The size of the end plate potential, it is proportional to the amount of the acetylcholine that binds to the acetylcholine receptors. If the end plate potential depolarizes the muscle membrane above the threshold, then there occurs the muscle fibrin action potential in the muscle. Under the normal circumstances, end plate potential is always above the threshold, resulting in the muscle fiber action potential. The amplitude of the end plate potential above the threshold volume needed to generate the that is muscle fiber action potential is the safety factor. Usually in all the normal muscles this safety factor is present, so that the end plate potential will always cause the muscle fiber action potential. There are two types of the repetitive nerve stimulation, that is slow RNS and one more is the rapid RNS. Slow RNS in which 2 to 3 Hz is given, and in rapid RNS 10 to 50 Hz is given. In normal subjects, what happens in slow RNS, acetylcholine quanta, they are progressively depleted from the primary store and fewer quanta are released with each successive stimulation. There is a progressive depletion of the primary quanta. And this results in the normal end plate potential which falls in the amplitude, but because of the in normal subjects the safety factor is normal, the MFAP is produced. You can see here this dotted line is the safety factor, and always the muscle action the muscle fiber action potential is produced is above the threshold. And after some few seconds, secondary store begins to replace the depleted quanta with subsequent raise in the EPP. That is, after the force stimulation, after fifth stimulation, there is the secondary store activation which results in the increased amplitude. But in rapid RNS, that is 10 to 50 Hz, in normal subject, that is a little bit complex. What happens? Let's see. The depletion of the quanta from the primary and secondary quanta occurs, and there is also the accumulation of the calcium in the presynaptic terminal. Because this normally it takes 100 milliseconds for the calcium to be actively pumped out of the presynaptic terminal, but in rapid RNS there is no time will be given, so new calcium influx occurs before the previously input calcium is pumped out, so this results in the increased quanta release. So there is an increase in plate potential, but in the normal patients there is a normal MFAP, that is muscle fiber action potential is produced, the height will be same. This is like all or none phenomenon, like all the muscle fibers are activated or no muscle fibers are activated. In normal persons happens this. So there is the same amplitude MFAP is produced. In normal both slow and RNS causes this type of the RNS. Then the effects of the slow and rapid RNS are very different at the molecular level, but in normal subject the result is same and consistent generation of the muscle fiber action potential. But in pathological conditions, the safety factor is reduced. That is, the baseline end plate potential is reduced, but still above the threshold, in which in postsynaptic disorders safety factor is reduced, but it is still above the threshold. This is the threshold that is still above the threshold. And then slow RNS, what will occur? Depletion of the quanta. First 4 you have seen there is a depletion of the quanta, and fifth also there is a depletion, reduced amplitude, because the secondary stores they cannot supply, and thence there is a decreased depletion of the quanta, resulting in drop in the end plate potential below the threshold. No or absent MFAP, because the calcium influx in rapid RNS, what happens? Calcium influx occurs, there is a increased acetylcholine, but in slow RNS this does not occur, hence there is a decrement of the response. In pathological conditions where the baseline EPP is below threshold, like in the conditions of the presynaptic disorder, initially only the threshold will be below the safety factor will be below the threshold. Hence, when we do the rapid RNS, there is an increased number of the quanta released, resulting in the large increased MFAP amplitude. And then slow RNS causes decrement and rapid RNS causes increment, seen in the neuromuscular junction disorders. This decrement occurs in the postsynaptic disorder, increment occurs in the presynaptic disorders. Then there is a formula, M is equal to P into N. What is M? M is the number of the quanta released during the each stimulation, and P is the probability of the release, that is, which is proportional to the concentration of the calcium in the presynaptic membrane, that is 0.2 in the normal subject, and N is the number of the quanta in immediately, that is primary store, that is 1000 in the normal subject. The immediately available store repletion, it occurs after 1 to 2 seconds. Then let us discuss about the effects of the slow RNS. In slow RNS means 3 has a repetitive nerve stimulation test. In normal subject, what happens? First, for stimulation, there will be the gradual decrease in the quanta, that is in 1000, 800, 640. That each stimulus 20% quanta are released. Then end plate potential will decrease in the initial 4 stimulation, and later it will increases. Then only MFAP is produced. And then MFAP is produced in all the conditions. This is occurs in the normal patients. From first to 4 stimulus, primary or immediate store is used. From the 5th stimulus, secondary or mobilization store is used. This results in the higher end plate potential. And then look here carefully. First one will see the 3 Hz, that is slow stimulation, slow RNS in case of the postsynaptic disorder. That is, the postsynaptic is the myasthenia gravis, and first 4 stimulation there is a gradual decrease in the quanta, and 5th is the increase. There is a normal, then decrement occurs, because the slow RNS cannot accumulate the more calcium in the presynaptic membrane, which results in the gradual decrease in the CMAP amplitude. In postsynaptic disorder like myasthenia gravis, the response, that is end plate potential to the quanta, is abnormal, that is safety factor is reduced. This is because of the fewer acetylcholine receptors. This end plate potential is initially normal because the nerve and presynaptic membrane is normal. Next, end plate potential is reduced gradually because of the depleted quanta, so it causes decreased MFAP or absent MFAP. And after the 5th stimulus, secondary stores are mobilized. Slight improvement in the MFAP and CMAP occurs, but it can't reach above the threshold. This is the slow RNS in case of the postsynaptic disorder. Then coming to the presynaptic disorder like Lambert-Eaton syndrome. In presynaptic disorder, what happens? N is normal, M is abnormal, release of the quanta, and the end plate potential is abnormal because end plate potential is normal for the number of the quanta released, that is M. P is abnormal, probability of the release decreases drastically. Example, in Lambert-Eaton syndrome, that VGCC defect will be there. There is a decreased calcium. As starting only EPP is below the threshold, so no or absent MFAP, decreased CMAP is seen. In slow RNS, there is further decrease in CMAP because of the decreased MFAP and depletion of the primary stores. After the fifth stimulus, the secondary stimulus are mobilized, stabilization or site improvement of the MFAP or CMAP is seen. You can see this is the slow RNS in case of the presynaptic disorder. But in presynaptic and postsynaptic, these are the fast RNS results. Like this is the green color one. Both are the fast RNS results in case of the postsynaptic, presynaptic and postsynaptic disorders. Effects of the rapid RNS we'll see. With rapid RNS, what happens? The depletion of the quanta, it is counterbalanced by the increased mobilization of the quanta from the secondary to the primary store, calcium accumulation in the presynaptic terminal, which results in the higher end plate potentials. So on rapid RNS in postsynaptic, this first one, green color, this rapid RNS what will cause accumulation. In the postsynaptic, initially it is above the threshold, first stimulation, then a little bit decrease, then secondary contact occurs and then there is an increment. But in presynaptic, initially there is a below threshold, presynaptic there is no response of the muscle. Once we give, there is accumulation of the calcium resulting in the more and more calcium influx, more and more acetylcholine release, and then there will be increment. In postsynaptic neuromuscular junction disorder, end plate potential increases, but usually the initial end plate potential is above the threshold. Then the result is the generation of the muscle fiber action potential. This is the this is seen. This is the picture. Neuromuscular junction. Usually the end plate potential is normal, that is above threshold at the beginning. If the end plate potential is lowered after the slow RNS, end plate potential decreases, fast RNS done, end plate potential is increased above the threshold. This is the postsynaptic. And presynaptic, usually the end plate potential is low, below threshold. Rapid RNS increases the end plate potential above the threshold, then MFAP is produced. Then coming to the exercise testing. During the exercise, the motor units fire at their maximal firing frequency, that is 30 to 50 Hz, which is similar to the rapid RNS. Like exercise for 10 seconds will causes the similar results as the rapid RNS because the frequency is 30 to 50. This is known as the post-exercise facilitation, that is post-tetanic facilitation. Post-exercise or the post-tetanic exhaustion, it occurs after the prolonged exercise or the rapid RNS after the 1 minute of the exercise. This you can see for the post-exercise facilitation and the post-exercise. D1 is the post-exercise exhaustion. And during the repetitive nerve stimulation, all measurements are made on the CMAP, that is sum of the individual muscle fiber action potential in the muscle. Hence the CMAP amplitude and area is directly proportional to the number of the muscle fibers activated. In normal patients, end plate potential is always above threshold both in the slow and fast RNS. Hence, CMAPs do not change significantly in the amplitude or area. Rapid RNS is quite painful and difficult to tolerate. Hence, it is usually rapid RNS is not done. Post-exercise exhaustion, that is muscle is exercised for the 1 minute. This is post-exercise exhaustion after 1 minute, but in the exercise testing, this post-exercise facilitation occurs after 10 seconds. Initially 10 seconds we can do fast exercise, that is like a fast RNS. And in the post-exercise exhaustion when occur, exercise for the 1 minute. This is known as slow RNS performed after 1, 2, 3 and 4 minutes. In normal patient with the normal safety factor, the end plate potential nerve falls below the threshold, CMAP amplitude and area remains stable. That is, it never falls below the threshold in normal patients. But in neuromuscular junction abnormalities, decrement in the CMAP amplitude and area in response to slow RNS becomes more marked 2 to 4 minutes after the prolonged exercise. Then there is a terminology known as pseudo facilitation, which occurs during the repetitive following the exercise testing. It is a post-exercise increments of the CMAP amplitude from the pseudo facilitation, but they do not exceed 40% in the normal subject. That is 40% higher than the baseline. It is caused by this is post pseudofacilitation. It is the normal phenomenon which is caused by the more synchronous firing of the muscle fiber action potential immediately following the brief intense exercise. Then what are the technical problems associated with the RNS? Movement of the muscle or the limb, CMAP configuration may change, and submaximal stimulation can cause CMAP decrements or the increments. This is the submaximal and this is the supramaximal stimulation. Then temperature. Ideal temperature is 33 degrees Celsius. In cases of cold, CMAP increment due to decreased function of the acetylcholinesterase, that is more acetylcholine binds to the AChR. And in the hot, worsening of the symptoms of the myasthenia gravis, the acetylcholinesterase is more active. Then withhold acetylcholinesterase inhibitor prior to the study. We should withhold acetylcholinesterase prior to the study, at least 3 to 4 hours before the study. Then nerve selection. Any motor nerve you can select. Most common used are ulnar, medium, musculocutaneous, axillary, spinal, accessory and facial. In postsynaptic neuromuscular junction disorders, weakness predominantly affects the ocular, bulbar and the proximal muscles. Then hence more proximal nerves are used, which are that is mainly spinal accessory nerves and the upper trapezius. This is the picture showing spinal accessory nerve stimulation. Then facial nerve can be used for the repetitive nerve stimulation, recording the nasalis, orbicularis oculi or any other facial muscle. But the problem associated with this are CMAP amplitudes are small at the baseline, hence changes cannot be detected and muscle cannot be immobilized. Then how will you calculate the decrement and increment calculation? Decrement calculation. The percentage of decrement is amplitude baseline CMAP minus the amplitude that is lowest CMAP into 100 divided by the amplitude that is baseline CMAP. In 3 Hz or the slow RNS, the lowest CMAP is the third or the fourth CMAP, as we already seen. Fifth or sixth increases in the amplitude. Any decrement more than 10% is defined as the abnormal. Normal subject should have no decrement or less than 10%. How will you calculate increment? In rapid RNS, the highest CMAP is usually the last one obtained after 5 to 10 seconds. Percentage increment is amplitude highest CMAP minus amplitude the baseline CMAP into 100 divided by the baseline CMAP. And in normal subjects, pseudofacilitation may occur up to 40% increment. This is normal subjects I am telling. And increment more than 100% it is seen in presynaptic neuromuscular junction. Between 40 to 100% are equivocal. Then decrement or RNS, it is seen in the following disorders. Disorders of the NMJ, severe denervating disorders like MND, and some myotonic disorders and metabolic myopathies like the McArdle's disease. Hence, to differentiate this, proper history, examination, nerve conduction studies and EMGs should be done. This is the protocol for evaluating the disorders of the neuromuscular junction. First, warm the extremity, that is 33 degrees Celsius. Immobilize the muscle as best as possible. Perform the routine motor nerve conduction studies, first to ensure that the nerve is normal. Perform RNS at the rest. After making sure that the stimulus is supramaximal, perform 3 Hz RNS at the rest for 5 to 10 impulses. Repeated 3 times, 1 minute apart. Normally there is less than 10% decrement between the first and the fourth responses. If more than 10% decrement occurs, is consistently reproducible, have the patient perform the maximal voluntary exercise for 10 seconds. Immediately repeat the 3 Hz RNS post-exercise to demonstrate the post-exercise facilitation and the repair of the decrement. If less than decrement or no decrement occurs, have the patient perform the maximal voluntary exercise for 1 minute and then perform 3 Hz RNS immediately and 1, 2, 3 and 4 minutes after the exercise to demonstrate post-exercise exhaustion. If a significant decrement occurs, have the patient perform maximal voluntary exercise again for the 10 seconds and immediately repeat 3 Hz RNS to demonstrate the repair of the decrement. Perform the RNS on one distal and one proximal motor nerve. Always try to study the weak muscles. If no decrement is found with the proximal limb muscle, a facial muscle can be tested, keeping in mind the technical consideration. If the compound muscle action potential amplitude is low at the baseline, have the patient perform 10 seconds of the maximum voluntary exercise, then stimulate the nerve supramaximally immediately post exercise. Looking for the abnormal increment, that is more than 40% above the baseline is abnormal, more than 100% is suggestive of the presynaptic neuromuscular junction disorder. If the patient exercises for more than 10 seconds and the nerve is not stimulated immediately post exercise, a potential increment may be missed. Always perform the concentric needle EMG of the proximal and distal muscles, especially of the clinically weak muscles. Any muscle with denervation or myotonia on the needle EMG may demonstrate a decrement on RNS. In these situations, a decrement of the RNS does not signify the primary disorder of the neuromuscular junction. Thank you.